Hello and welcome to the Vulnerable Migrants in Health Challenges and Support webinar. So this is part of our Black History Month celebrations. Thank you for joining us today, and we'll be using this space to discuss the challenges and support available for vulnerable migrants regarding their access to health services. So just to note, when we refer to vulnerable migrants, we're speaking about asylum seekers, refugees, unaccompanied children, victims of trafficking, low-paid migrant workers, and undocumented migrants. So their vulnerability in relation to potential health needs are due to their experiences either before, after, or during migration. So I'll just go through some housekeeping for today's event. If you can keep yourself on mute so that we can hear all the presenters speaking throughout the event. All the questions that you have, can you please put them in the Q&A box or in the chat box, and we'll respond to them after all presentations are complete. This webinar is being recorded, so you will remain anonymous as we cannot see you and your name's not displayed. And we'll be sharing the recording on our YouTube channel, which is BHA for Equality, and I'll put the link in the chat box as well. So today we're joined by 4 experts who will be delivering their presentations throughout the webinar. And I'd like to introduce Elisabete Miranda, and she's a sexual health advisor and HIV testing lead at BHA for Equality. Gurdeep Ziara, who is a COVID chat volunteer coordinator at Manchester Health and Care Commissioning. Nyambe Mukelabai, who is a sexual health improvement advisor and asset-based community development lead at BHA Leeds Skyline, and Leah Payne, who is the senior advice and guidance officer at Healthwatch Bolton. And I'll give them a few minutes just to talk about their positions and what they do when they present as well. So I'll hand over now to Elisabete with her presentation. Thank you.
Hello, I'm going now to first share my screen. I hope everyone's seeing. So as Chantelle said, my name is Elisabete Miranda. I'm a sexual health advisor and HIV testing lead. And I'm working for PASH, that is a project in Greater Manchester, based in Greater Manchester, for the promotion of health and prevention of HIV and other STIs. During our work, we have a partnership with different organizations, and several of them are refugees and asylum seeker support organizations. So today I'm going to talk a little bit about refugees and asylum seekers, so vulnerable migrants. As my colleague already said, and just to explain a little bit better what is vulnerable migrants, there are asylum seekers and refugees, unaccompanied children, people who have been trafficked, undocumented migrants, and low-paid migrant workers. Our aim today is to discuss more the refugees and asylum seekers, although all these majority of asylum seekers and refugees will have these other problems of being people that have been trafficked, the low-paid migrant is all crossover. So we meet today for this discussion because definitely there's certain group of migrants are more vulnerable to potential health needs because of their experience and for refugees and asylum seekers, their experience of migration during or after. The relation between migration and health, it's complex and impacts very different groups of migrants, and then could be different from each person. So experience of one person can be different from another person. Not everyone is equal, so we need to respect the difference, the group of migrants and the person itself inside of that group. And the lot of vulnerabilities is because of the lack of legal status, the stigma, the discrimination, language barriers, low income levels, that can exclude people of accessing primary health care service, vaccination campaigns, and health promotion interventions. Just to have to give a little bit of an idea how many asylum seekers and refugees, well, in this sense, asylum seekers, that I'm going to show you, just because they are more vulnerable in living in Northwest. We have around 8,635 asylum seekers placed in accommodation in Greater Manchester, in Northwest, and from these in Greater Manchester is around 5,309 living in Greater Manchester. And Greater Manchester is actually, and Northwest is one of the areas with more asylum seekers and refugees in England. Just so as well, we can see here a trend that of decline of the numbers of the asylum seekers in UK and in England as well, and this is for various reasons. One of them is different policies in terms of migration with Brexit, and another one that is very important is about the pandemic, of course, that impacted the number of asylum seekers that England is receiving. There's a belief that UK receives a lot and several refugees and asylum seekers do the NHS system. And then people sometimes want to come to England because of the health system. And I just wanted to share here, just in comparing with the other countries, that actually UK is not the country that receives more asylum seeker applications. So there are other countries. So comparing with, for example, here with the countries from EU, Europe, there's Germany that has received so much more, France, Spain. So EU receives and contributes for integration of asylum seekers, but this belief that we are the countries that receives more is more a myth. And if we compare with other countries of the world, definitely like Lebanon, Uganda, other countries receive much more asylum seekers than UK. So, but then we are talking about health. And so what's a common health challenge that the refugees and asylum seekers usually have? This is specific for UK, or is a general problem that refugees and asylum seekers face. That is poorly controlled chronic conditions, and that is like hypertension, diabetes, epilepsy, badly healed injuries, and out of medication, because sometimes they don't have access to medication. Maternity care is also a big problem for women that are refugee and asylum seekers. So they usually, the women are more late, they present later in the GP, they some have a FGM complications, trauma, malnutrition, all overall the access to in terms of supporting pregnancy and maternity is lower than other groups. Mental health and is a big problem in terms of health for refugees and asylum seekers, and they face all the obvious reasons, problems like depression, isolation, PTSD, torture, FGM. And another big one is untreated communicable diseases, and this is TB, HIV, one of in our organization, BHA, that works is for the prevention of HIV, and then that's the reason it's a big number here for vulnerable migrants, parasite infection and missing vaccines. And now we are inside of the COVID-19 and promoting vaccines. And this is another problem that a lot of refugees and asylum seekers face from not having. And why? What's the reason? What's the barriers that they face that they are not accessing? There are several of them. I'm just going to say some. I think the main ones, and one big one is associated costs. So a lot of asylum seekers don't have a way to afford the costs associated with their healthcare, and sometimes like travel and prescriptions are the big issues because it's free. So to access NHS is free, but sometimes even, for example, if you have an appointment in hospital or if you have an appointment in sexual health clinic and you don't have money for the bus pass, it'll be hard to go to the appointment or don't have money for the prescription of the medication that your GP passed. So that is a barrier. And then NHS charging policy. So the NHS charging policy in England has made healthcare unaffordable for many people, refuse asylum, and cause confusion about whether individuals are eligible for free healthcare or not. So it's actually asylum seekers and refugees, they are entitled for free NHS, but the ones that are refused asylum, they can face some charge. And also now with the different laws and regulation in terms of migration, for example, EU and other migrants now need to pay for a visa. When they paid for the visa, they pay for the NHS cost. And all these different ways of charging and different migrants are applied different things are very confusing for the asylum seeker and refugee, and also for staff working on NHS. Data sharing with Home Office. Refugee and asylum seekers are very concerned they may be arrested or detained, or because they are afraid that they are sharing the information with the Home Office. So sometimes they don't access the health service, don't go to the GP because they are afraid that we will share information. Language barrier, of course, is a big issue because communication is a key for improve your health and to assess to health service, and language being a big issue. Even with interpreters, sometimes they don't even know how to request for interpreters, so the language is definitely a big barrier. No choice dispersal. So most asylum seekers are allocated accommodation by the Home Office and can be moved without choice. So that is the continuity of healthcare. For example, just giving one example. So for example, one asylum seeker can be placed in Liverpool, and then they have an appointment with GP or they have diagnosed, and then suddenly they change it for Manchester, for example. And they lost track sometimes, they lost the dress, or and then the treatment don't continue. And even if they prepare, for example, they have a relation of trust with some GP and then they change everything again, very unstable. So this is it's a big barrier for accessing healthcare. Lack of knowledge. Some health professionals, and I'm saying lack of knowledge, not just for the refugee and asylum seeker, also for health professionals, that of entitlement and the eligibility of asylum seekers to healthcare. I already said that the system is quite complex, and some are not aware actually what asylum and refugees and other migrants are entitled. A health condition, some were worried about their health conditions, particularly those considered stigmatizing, such as HIV, for example. Some are, or mental health conditions, or some are concerned, oh, if I disclose my HIV status, for example, that can be considered in my asylum process, or I'm not going to disclose. All these issues can block people of accessing the health service. And now with the pandemic, COVID-19 pandemic, has exacerbated all these vulnerabilities of migrants. Everything is more difficult, and this it is due to socioeconomic restrictions have put livelihoods of many migrants at risk. I'm not going to talk much about this because we have another panelist who will probably explore more this topic. In terms of supports, there's some support has not been working, but I think the important message to pass is no matter what the immigration status, everyone in the UK is entitled to free emergency and primary healthcare. But of course, with all the issues that I already told, some, for example, if you have visa, probably will pay some charges. But everyone have access to emergency and primary healthcare. People seeking asylum should be given a HC2 certificate when they're granted support from the Home Office. So this is not for the people that are refused asylum seeker. For people can, if they are asylum seeker, they can ask for this and they'll have support for example, prescription medication. So it's free to access it, but then some people struggle to have the medication, and actually they can have this, but sometimes they're not aware. Medical staff actually sometimes are concerned with the situation. They refer to council service, but council service sometimes are not available due to and now with COVID and the pandemic, the lists are very big for counseling and this kind of mental health support. And there's some training, but very low to medical staff about the entitlements of refugees and asylum seekers. So the majority of people don't know. So probably maybe in areas where we have big concentration of asylum seeker refugees, we need more training for GPs and medical staff about the refugees and asylum seekers. There's available interpreters. So if people go to NHS service or GP hospital, there's available interpreters for refugees and asylum seekers, but sometimes they don't know how to ask. Even some interpreters, they actually don't interpret quite like they want, and sometimes they actually have difficulties to disclose everything when it's the interpreter, for example, is from some country and is disclosing problems such as, I'm going to talk about HIV again, due to our nature of our work. They have difficulties to disclose, for example, sexual health history to when the interpreter from his country is there. So it's kind of tricky in terms of health. And there's some resources in different languages. It's not enough. Sometimes appears some, disappear, and then it appears again. Sometimes people don't know where it's available to these resources. So it's definitely needed more resources and consistent resources in different languages. And the one, I think, in terms of support that is being amazing is the charities. So the charities are acting as a lifeline for those trying to navigate to the asylum and healthcare system. So there are several organizations that support the asylum seekers and refugees. These charities are actually that are promoting the vulnerable migrants to have access to the things that I said previously. So there's several charities in Greater Manchester, for example, the Solution Project, British Red Cross, BRAS, SWAP, Wigan, several organizations that support these refugees and asylum seekers, and it's very, very important for them, not just in terms of health, but in terms of everything, housing, application to the Home Office and others. So with this, I'll end my presentation about the importance of how charities support refugees and asylum seekers to promote and to improve their health. Thank you.
Thanks a lot for that, Elisabeth. Some really interesting information there that you shared with us today. I've just put the email address for PASH in the chat box as well, if anyone needs to contact Elisabeth for any more information. I'm going to pass over now to Gurdeep.
Thanks, Chantelle. Hi, everybody. My name's Gurdeep Thiara, and I'm a CoverChat volunteer coordinator. And I work for Manchester Health and Care Commissioning, which is kind of a mix of council staff and NHS staff. They kind of come together and they commission services. And one of them is the one that I work on, which is part of the Community Champions programme. I met Elisabeth at a community centre called Rainbow Haven, which is in Openshaw in Manchester. And they do some really important work that she's highlighted, supporting refugees and asylum seekers and vulnerable migrants. And we just got talking there about the CoverChat approach, which is what I want to speak about. I don't have a presentation, so I hope you can follow everything I say. However, if you do want to know in more detail about the CoverChat model, I can email that to you. I'm going to talk about the work that we did with Rainbow Haven. There's a report that was written by the medical student that I worked with there called James Millwater. I can email that to anybody as well that's interested, because Rainbow Haven set up, like they called it, a vaccination project. So it was about improving and access to the vaccination, access to health staff to ask questions about the vaccination, and also to promote other services relating to people's healthcare. And that's all been written up in that report, and it's really valuable. And it's been something that I've also been able to share back with my colleagues in the NHS and the council, for them to be able to act on those recommendations in the report. Because I think the way that everything joins up is really, really important, particularly for this group, because I think they're not always seen, they're not always easy to find, because of the reasons that Elisabeth has covered. A lot of the hostile environment in terms of laws around immigration don't make it easy. The asylum system is very unfair. Home Office hasn't treated people well. So when they become undocumented, they go underground for different reasons. There's lots and lots of mistrust. And this is the backdrop in which we're all working to reach these people. And I think services like the CoverChat program is one way to make light of all of these issues. And that comes through the conversations that we have with staff working in this sector, and also the conversations with service users. So what is the CoverChat program? So it started in 2020 in response to the pandemic. It sits under something called COVID Health Equity Manchester. So the word equity is really key here, because that recognises the huge inequality that exists, particularly for people of colour, in accessing all kinds of services, not just in health, but also in education and employment. Has a massive impact on their health and well-being. What became evident through the pandemic was just how worsely affected Black African, Black Caribbean, South Asian people and people with disabilities. They were sadly, some of the highest people who died because of COVID. And also there were higher cases of COVID amongst those groups. And the uptake of the vaccine was lower. Those categories that are used, those tick boxes, how we identify our ethnicity, they're not something that everybody completes all the time. They're limited. So, in terms of South Asian audiences, South Asian people, you've got Pakistani, Bangladeshi, who are identified. But I think in the category of Black African, it's huge, but it's not then broken down. So some work needs to be done around that, but I think it's really key because it's in terms of the Equality 2010 Act, it's an identified characteristic, ethnicity, because it recognises that people are discriminated against because of that. So I think there's something very important about us still being able to identify our ethnicity in terms of how we use services, so it can highlight where the gaps are, where funding can be put in order to address some of these problems. But all of that work takes a long time, so it doesn't immediately give us the answers overnight. The COVID chat programme grew out of that recognition of, okay, people in Manchester who are from that heritage, they need more resources, they need different approaches to be able to reach them, to be able to give them reliable information, to be able to give them information in the language that they need, to be able to hear that things like, okay, I need to get the vaccination, where do I go? For somebody that's living on just over £5 a day, is an asylum seeker, how are they going to afford the travel to go to the vaccination centre? That information came back through the work that we're doing. It fed into the council, they acted on that, so they are able to provide a taxi for anybody that might need to go to a vaccination centre. In terms of the language support, that needs to be really consistent. At the moment, it's provided in 15 different languages through the council. They produce like a community toolkit of messages that are easy reads, picture-based, and we're trying to build on voice. Not everybody can read in their first language. Videos help, audios help, just so that people can get the information that they need. So I'm going off on a few different tangents, but the COVID chat model is, it's basically a program that promotes the request. People can make a request to have a chat about COVID. Those chats are very person-centered, they're non-directive, and they give people factual information. So reliable information about the vaccine, and also a chance for people to be heard, to talk about things that they might be worried about, what they need help with, how COVID has impacted them. So the COVID chat isn't just about the vaccine, but that's a part of it. I work with 3 other people who do the same role as me in Manchester Health and Care Commissioning, and then we have another 13 volunteer coordinators who are attached to different community centres and organisations, including Black Health Agency, out in the community, and also based in an organisation called Breakthrough UK, which works with people who have disabilities. We're trying to also promote through the programme a chance to recruit volunteers and champions who can deliver the chats. So we've trained up to about 70 champions. We started in May and we're now in September. Those 70 are made up of people who work in the public sector, but they have a real forward-facing role in their communities. So COVID might come up in those conversations. We've also trained people in community centres like Rainbow Haven, for them to be able, for their staff and their volunteers to be able to talk more confidently about COVID with their service users, and then service users directly. So what we want to do is try and recruit people who can speak different languages. So we have a number of languages at the moment, which include Urdu and Punjabi, Kurdish, Farsi, Arabic, Igbo, Hausa, Yoruba, Spanish, Lingala, Portuguese, French, Cantonese, and Mandarin. The idea is that people do the training, it's 2.5 hours long. They find out how to do that person-centered chat. There's a bank of resources all relating to COVID, from translated materials, Doctors of the World, videos. There's a key public consultant that leads on this programme called Dr. Cordell. She's produced what we call COVID Classroom, which is just some videos that help to kind of answer questions that are coming up through the chat about what the side effects of COVID, of the vaccine. I'm worried about those. What does it contain? There's been ideas that it contains pork or other animal products, where it's going to affect people's fertility. These are some of the concerns that people have got about COVID. So those are answered, those are covered in those kinds of videos. And then people are then, most people are talking about COVID through their work, with their family, with their friends. And that's where the chats come in to their own. That peer-to-peer conversation about COVID is really important, because people aren't always listening to services or professionals. Some people are fed up. But their influence is there maybe through their friends. And it might just take one person to talk to them and say, I've had the vaccine and I'm okay. And that can make a big difference. We want to have more people to do the training, just so that we can reach people. This group, they're not connected necessarily to services. So where we're able to reach them, we can do some joined up work together, like Rainbow Haven did. And going forward, so through the work that Rainbow Haven did, there were people that were able to access the vaccine. A pop-up was set up at the Rainbow Haven Centre, and there were professionals there that people could ask questions to. And I think about 25 people through that work were able to go and get vaccinated. Going forward, the request is for people to maybe have these chats on a regular basis, but also have some input from health professionals where they can ask specific questions. Because the pandemic, we haven't got through it. And there's still lots of problems that are going on for people and how it's affecting them in terms of their everyday lives. One of the biggest challenges is that we can't always find people. So Elisabete mentioned that there's, you know, maybe over 5,000 people in Manchester, where they are, whether they're not all registered with GPs. So being able to find them is a challenge. Or some people don't want to be found. And I think there's a lot of work to do in that joined up way, but also there's a lot of work to do to build up trust, because that trust isn't there for lots of reasons that are historical. And that's, yeah, I think that's really key. So yeah, I've talked about lots of different things, but if anybody wants to pick up these conversations with me after, please email me. Thank you.
Thanks a lot, Goody. It's just so important to have initiatives like the COVID chat model and the volunteers going out in the community, isn't it? To share that information, the reliable information on the vaccine, and so they feel heard, and also building that trust, like you say. If you want, you can put your contact details in the chat box so people can contact you to continue this discussion as well. I'm going to pass you over to Nyambe.
Hello, hello everyone. Thanks, Chantelle. My name is Nyambe. I work for BHA Leeds Skyline Service as a sexual health improvement advisor, more specifically in asset-based community development as a lead. I know some of the things I was going to say have somewhat been covered, but my task is to look at how we as a service, in Leeds, actually try to ensure that people do have access to the services that they need. Going back to some of the things that have already been alluded to, we have a situation here where we're discussing people coming into the country in various statuses, various different levels of enlightenment, different languages, different cultures, different religion, and some coming in statuses that may be not clear in terms of whether they are regular or irregular. People coming in to work in some of the, low-skilled jobs or high-skilled jobs. So there's a whole array of situations for, of migrants. Now, on the other hand, they arrive in a country which has a health system that really would need to be navigated. We have, on the other hand, services that are considered to be free. For example, some of the services in primary care. And then we've, as has been mentioned by the two previous speakers, we have the chargeable services. We have the regulations that were passed a few years ago to specify that certain secondary care access is chargeable. Now, when you have that situation, how do you get people who need these services to really navigate a complex health system? Elisabeth did point out also that apart from the question of navigating the system, you have people who are experiencing different circumstances in terms of the socioeconomic conditions they are in. You have people who are trying to sort out their housing, work, and get to a situation where, in a lot of circumstances, not necessarily by design, health is left at the bottom of the pile of their priorities. Now, in practice, how, as an organization like ourselves, do we link these people to the services that they actually need? And those are the vital questions in a world where we're always talking about universal access to health, in a world where we're always talking about the right to health. We're always talking about fulfilling the Sustainable Development Goals, where no one is left behind in terms of accessing health. So on the one hand, we have the theoretical basis of what services are free, what services people can access. But in practice, are we really ensuring that no one is left behind? Okay. Now, at BHA Lead Skyline, one of the first things we look at when we try to communicate with the communities we work with is what is their level of understanding, what needs to be done? How do we communicate what health services they can access and how they can access them? We've developed some resources here over the years with some of the members of the particular communities to explain certain things in a language that is simple, in which they can understand. For example, if they want to have a test, we have some interpretation of what that test entails. We have, in some circumstances, developed even pictorials, which we use in some of the educational settings. We have also ensured that we develop some rapport with some of the community leaders within some of those communities, because we know that community leaders are assets in themselves, and they can be able to deliver information in a language that the people in the communities can understand better. So if we train them or we have a conversation with them, they can more constructively develop, communicate this information to members of their community. So that's one way of getting around. And all this information involves reassuring people that sexual health services are free, together with a host of other communicable diseases, which are listed in terms of access, that these are free. We also, whenever we can, work with the staff from the NHS Trust themselves, because sometimes we forget that although they have difficulties in navigating some of the regulations themselves, we need to have them on our side as allies. We need to have the health staff in situations that we can to come on board with us in our linkages with these communities. And also for the community members that are, for one reason or another, do not want to engage with specialist health services. And one of the reasons Elisabeth gave there was the fact that some people will be thinking that the information they share with the health service will be communicated to other authorities that they do not want to have their communication. So we have to work in such a way that if we know certain services cannot, if people cannot access certain services in those specialist settings, should we take some of those services into the communities themselves? And we've done that together with some of the health staff. When we've gone out to do screening and testing, some of the health staff have come with us. And that is a way of getting some reassurance and trust from the community when they see the health workers in the community itself. And they keep being reassured that whatever is done, whatever information they give will be held confidentially. That helps in people engaging. In fact, in terms of some of the screening and testing, people are told they don't have to give their real names. They don't have to divulge that information. And that's also develops some kind of trust as to them accessing the services. Some of the other things we've done is to link up with the other third sector organizations that work with the very people we work with. The very people who want to access the services also go to other third sector organizations for all kinds of things. So we've created links with some of these organizations, first of all, to convey the information about what health services are available, which services are free, and how they can be accessed. But the other thing is also to actually train some of the staff in these sector organizations around some of the barriers to accessing health, and also to talk about issues around discrimination, issues around stigma, because sometimes even the professionals in third sector organizations need to understand some of these barriers and not unwittingly working to discouraging or actually discriminating some of the members of the communities themselves, or because of the fact that they may not have some information, exacerbate some of the stigma. So I think training is also important in terms of us relating to the other organizations as to what we actually do and how they can inform people who come to them as to how they can access some of the services we offer. But we also do get a lot of information and training from those very organizations so that we understand what people are going there for and they understand what people are coming to us for. And I think one of the other things that I think Tiara referred to is the fact that we need to get migrants and people from these communities involved in the actual planning and design of some of the, when we identify some of the needs and we want to investigate further as to what should be done, I think the members of the communities themselves should be involved in the design and implementation of those services. When we have done a few projects, for example, we did a project involving faith leaders from the communities in bridging this gap. We did find some sentiments from community members where, when you look at them closely, you find they think there's a disconnect between themselves as health users and the providers of health. So we have to come in between there and bridge this gap in one way or the other, because there was an example given by some of the community members that when there were several lockdowns to do with COVID, and there was information coming from public health, they thought the providers were not explaining things in the way they thought they need to understand them. The information was out there, but did they know whether the communities are looking at that information? Did they know whether the communities are actually reading it? Did they know whether the communities actually understood the information? For example, did the communities, the migrants, including those of irregular status, did they understand that the COVID test was free? COVID, for those who needed the treatment, was free for anyone, regardless of their status. And this information was issued by public health. We could read it, other third sector organizations could read it, but did it really permeate? Was there a direct link with the communities to tell them this is the situation? So we have a big role to play in making these linkages and asserting to the communities what rights they have, so that they don't feel left out and they don't think that engaging with authorities means they'll get into one form of border or the other. Thank you. Sorry if I know there's little time left, but if there are any questions, we can look at that towards the end. Thank you.
Thanks a lot, Nyambe. Yeah, the time's gone really quick, hasn't it? And I'm sure there's so much more that we'd want to discuss. Maybe need to do a part 2. I'm going to pass you over now to Leah, and she will do the final presentation of the webinar today.
Thank you, Chantelle.
You're welcome.
Thank you. Just put it on full screen. That's great. Hello, everyone. Oh, can we have it on full screen, Chantelle? Are you able to do that for me? Perfect. Thank you very much indeed. Good afternoon, everyone. My name is Leah Payne, and I'm the Senior Advice and Guidance Officer at Healthwatch Bolton. Today, I'm going to talk to you about what Healthwatch does and how you can get involved in our work, and basically the nuts and bolts of what we do more generally. So Healthwatch is a local consumer champion for health and social care. So what that means is that we work very closely with patients and the general public, and the real nuts and bolts of what we do is to improve local services for local people. Healthwatch was set up in 2013 under the 2012 Health and Social Care Act. There is 151 health watches nationally. There is one in each local authority. Greater Manchester has 10 local health watch, and I won't go down the list there, but you can see that we've got our 10. We've got our national body is Healthwatch England, and if you wanted to find out where or who your local health watch is, all you need to do is go on to the Healthwatch England website, and it will, I think it's one of the buttons at the top, it says find your local health watch, and then you can put your postcode in there and it will tell you which one is your local health watch. You can contact them. Thank you. Can I get the next slide, please? So our vision is really simple. We want a health and social care that works for the people. We want it to work for you. We want health and social care to be improved, because we know it's not perfect. We know it's not all a one size fits all. So we're really interested in listening to individual views and experiences. Having good health and social care helps people to manage their health conditions far better. And ultimately, we want people to get the very best out of their local health and social care services. So our purpose and how do we achieve our vision? We go out and we speak to people about their experiences and their views. Before COVID happened, we were very active in the community. We'd go to care settings, so that would be nursing homes, GP surgeries. We'd go out to community groups as well, and we'd speak to people about what matters to them. And then what we do is, and we take that information and we write reports and we feed that back to commissioners and key decision makers. Can you get the next slide, please? So our approach is that people's views do come first. Our greatest strength is that we are independent, and therefore we are committed to making the biggest difference. And we really do champion what matters to people. And I'll talk about a number of areas that we're currently working on and have worked on for years. But what I'd be really mindful is at this stage is to say that Rome wasn't built in a day. And there are some issues which are long-standing, but we have to keep working. We have to keep pushing to make the system better, to make it work for everybody. So how do we ensure your voice is heard? Well, like I said, we physically go into the community, and we want people to tell us your views. We also have the information, advice and guidance service, which is what I work on. So people will come to us if they want to find out what's happening locally, but more often than not, people come to us when things haven't gone according to plan. So what we'll do is we'll take notes, we listen, which again is one of our greatest strengths. And then we can, although we don't investigate individual complaints, what we do is we act as a bridge. So we can take your inquiry and escalate that to the people that are in a position to make a difference and to actually move things forward for you. So like I've just said, we tell commissioners and service providers. We also share all our intelligence with Healthwatch England, and they're really active in working on some national initiatives. So for example, I know that access to GP appointments is really critical at the moment, as is access to NHS dentistry. During the COVID-19 pandemic, although we're still in it, but at the very height of the pandemic, we did a big piece of work around hospital discharge and safe hospital discharge as well. Healthwatch England does take our intelligence and share reports with the government. And to ensure and to build trust in Healthwatch, we then feed responses back to yourself. So it's a case of you said, we did. We really want people to share information with us. And the only way we can gain their trust is by actually saying evidence. Well, this is what we're doing with what you're telling us. Thank you. Can I get the next slide? So as I've just mentioned, this is how we make a difference. We ensure that commissioners and providers of health and social care hear views, and we produce reports, and we also set our yearly priorities. From the reports, we make recommendations for positive change on what people have told us. But we're also keen on sharing positive feedback as well, because as much as we want to know what's not working, we feel that knowing what's working really well is really boosts the morale of our health and social care professionals. So it's and it highlights what's working really well too. So it's critical that we get that information as well. We do work across the network. We work across Greater Manchester and across England to ensure that we've got a stronger collective voice. As I've just mentioned, NHS dentistry is an area that we've done so much work on, and we've managed to get it in Parliament, and we've managed to get some national coverage, not just recently, but about 7 years ago in the media as well. And I know and the NHS dentistry isn't perfect, but it's something that we're not going to give up on, and we do work very closely with the commissioners and the dental professionals as well. And what's been really key in that piece of work is that the dentists are actually on our side. They realise that there's an issue, so it's not about us working in separation, it's about us working together. And as I've mentioned, we do share intelligence with our local partners. So our intelligence is what people tell us, and we share that with the Care Quality Commission and the local authority and the clinical commissioning groups. We also make a difference by helping to get key messages out, and we were really active during COVID-19 and still are, in making sure that people are aware of vaccination programmes. We've volunteered as well. So when Bolton had the surge in the, I think it's a Delta variant several months ago, we were out with other organisations encouraging people to come forward and get tested and to share some really key information into myth bust as well. And just going back to the healthy information and signposting surveys, we do help people to navigate what is very often a very complex world. Sometimes even when I'm working in it and when we get faced with a new inquiry, it's like, okay, where do we start with this? And if it's difficult for us as professionals to work within the system, then how difficult is it for someone who is new to the UK? Ultimately, we do strive to make sure that all the voices in our local community are heard. And in response to that, what COVID-19 highlighted for us as Healthwatch Bolton is that we need to reconnect or establish our previous relationships with the community, but also to reconnect with the groups that are seldom heard. And we realise that that is a gap on our part, and we are working very hard towards that. As a result, we employed our engagement officer, Yasmin, back in January to help us plug that gap and to do some really meaningful work with our diverse community in Bolton. Can I get the next slide, please? So just to give you a bit of a flavour really of the work that we do, because although we're not an organisation, Healthwatch isn't, generally speaking, Healthwatch doesn't work with specific groups. We work with the whole community, but we do undertake specific targeted pieces of work. So for example, in March, we worked in partnership with the Flowhesion Foundation, and we produced the COVID report, which specifically looked at the impact that COVID had from people from Black, Asian and minority ethnic communities in Bolton. That report is on our website too. We've also done some work around cervical cancer screening, and as a result of that, we've got a pilot that's running in the Runworth area in Bolton, and once again, that's working with, I think it's South Asian women or other Black and minority ethnic women within that area to increase the uptake of cervical screening. We're working very closely with Bolton Clinical Commissioning Group and the GP Federation on that. And that piece of work has come directly out of that report. Healthwatch Hackney did a report, and that was based on 54 interviews with refugees and migrants into the barriers they face with accessing healthcare. That was back in 2020. And Healthwatch Redbridge commissioned the Refugee and Migrant Forum to investigate issues around access to healthcare for vulnerable migrants. So we do specific pieces of work, and a lot of the work that we do again is led by the intelligence that comes through from our engagement through online surveys and also through the information, advice and guidance service. Can I get the next slide, please? So our key projects for this year are access to primary care. As you've probably seen in the press, are more than likely had some real personal experience of this, accessing, getting to see your GP, making an appointment, even getting through on the telephone has become really difficult for a lot of people. So we've got a live survey at the moment that closes at the end of this month, next Thursday, and currently we've got just over 400 responses to that survey. It's a really big piece of work that we're doing, and we are working very closely with the Bolton Clinical Commissioning Group on that, and we really have tried to get a broad range of views. So we've really hammered that survey out. Unfortunately, we're not in the community, so we have to work even harder to make sure that the responses we get are reflective of our local community. We're still doing a big piece of work on NHS dentistry, and as I've just mentioned, the work in the Runworth area around cervical cancer screening. We're also involved in some work around secondary care. So once again, the national picture is that because of the pandemic, the waiting times for secondary care is incredibly high, and people are having to wait years, months, if not years, to have elective care, which is routine planned operations in hospitals. So we're doing a piece of work around that. We're also looking at adult mental health, and we continue to make links with our community, and we are hoping to work with younger people in the future. More information can be found on our website about our key projects. Can I get the next slide, please? So how we can help you. Again, I feel like I'm going over stuff, but we can certainly help you to navigate the health and social care system by you contacting our information, advice and guidance service. It's worth noting that some health watches do have the advocacy contract, and where that's the case, they can investigate formal complaints. But if it's a complaint around social care, then all health watches will work very closely with their local authority. We do encourage people to come and have their say. We do have surveys that are online, although we are increasingly starting to get out into the community. It's worth adding that all our surveys are anonymous, so you feel free to really be honest about what your experience has been, but there's no way we can identify you from that unless you leave your details for us to contact you. Yeah, you can contact us at any time at all, and we have the social media, we have a website, and I'll give you our details at the end. And we also have a newsletter as well that comes out on the 1st of every month, and we always encourage people to let us know what's happening in their local area, and we always make sure that there's stuff in there which is for everyone. And once we start opening, I'm sure that we'll have some volunteering roles too. Can I get the next slide? Yeah, there's our contact details for you to get in touch with us. We are open, our core office hours are 10 a.m. till 3 o'clock in the afternoon. And I think that's it. I am conscious of time. I think we've got a question at the end, which I'm happy to pick up on, but I'm happy to answer any other questions as well. Thank you.
Thank you so much, Leah, and thank you everyone, to all the panelists today. for the presentations that you've delivered for the webinar. So I'd just like to use this opportunity, if that's okay with everyone, to ask any questions. I'll just have a look in the chat box as well. So we've got our first one, and this one is for Elisabete, which, you know, I'm sure many people have discussed this as well and gone over it, but is why do vulnerable migrants face more health problems compared to other migrants?
As I'm questioned of time, I'll try to answer very quickly.
Yeah.
Kind of explain in the PowerPoint some of key problems of vulnerable migrants, and they face several different challenges more than other migrants that they do per choice. So some people just migrate to the country per choice. When you don't have that choice, it's sometimes you face other problems such as stress, depression, everything involved when you're running, that is running to save your life. So that is the reason that they are increased health problems. It's not because they have more problems than others, they just face more challenge than others, and that impacts their health.
Thank you, Elisabete. I've got a question for Gurdeep. So when you talk with the refugee, asylum seekers and other vulnerable migrants about COVID, what do you find that their biggest concerns are? And do you think that they've got different beliefs about, different beliefs from the general population regarding COVID and the vaccination?
Yeah, I think in terms of the question about what's coming up for people about COVID in terms of the vaccination, I think it's a lot of the things that we mentioned and Elisabete mentioned around practical difficulties that people have. The asylum system is a really lonely place. I think people in the asylum system, they're in limbo when they're waiting for their decision. So in terms of priority, we found that the vaccine was sometimes quite low down the list because they were worried about their asylum claim or their housing. They often live in really poor housing conditions. Money issues, you know, just those very practical things that have a real impact every day on people's lives. In terms of beliefs around the vaccine, I think that's really wide and varied, but there's a commonality in terms of like the idea of the mistrust around the vaccine and the lack of information about side effects, the worry that it's developed really quickly, it's not been here long enough. I think those are common across all the population and across the globe. I mean, conversations I've had with my family in India, there's the idea of the kind of conspiracy idea around the vaccine. I think that exists for a lot of people. In terms of other beliefs, I think it's mainly about the right information, because the messaging has been confusing. It's meant that people are vulnerable to misinformation, and I think that's what's feeding people's beliefs.
Thank you, Gurdeep. And we've got a couple more. So this one's for Nyambe. So you mentioned, like, you know, refugees and asylum seekers, they can be, you know, quite frightened to, you know, share any information, maybe the HIV status or the sexual health, sexual history, and how that can have a negative, they feel that can have a negative impact on their home office application. How do you at, you know, Leeds Skylight ensure that there's trust, you know, in that client when you're providing your service?
Okay, one of the first things we assure our clients with its confidentiality. But this begins with the staff themselves, because part of policy requires that everyone is actually trained around confidentiality and is aware of the policy of confidentiality, so that when whatever information they use and whoever they speak to, they have that in mind. But also in terms of directly engaging with the clients are often reassured about the fact that there's a distinct separation between the service they need and the other status they might be in. We know that, and we also refer to the regulations and legislation that clearly states that all sexual health services are free, including, of course, some of the other communicable diseases. They are free either from ourselves or they're free from the NHS premise. And that information they give will have nothing to do with the pursuit of regularizing their status, for example. So we do that, and when they are being screened or they're testing, and whether we're working with staff from the NHS or working here, we also always reassure them that the information we keep is often kept for a certain length of time, and we get rid of it, or we tell them how we keep it. And we also tell them that if it's just for purposes of screening or testing, they do not actually need to give their names. They can just give us enough information for us to take the statistics for our own data, but they do not have to give their names.
Thanks, Nyambe. And I've got one for you, Leah. So could you explain the importance of coordinating and integrating different community services to support vulnerable migrants, and how this can be vital for their general health? Oh, you're on mute.
I do apologise for doing that. So coordinated and integrated community services provide people with a holistic and a seamless, smooth approach to them accessing the services that they need, that are provided by people with the right skills at the right time, ideally at a local level. This approach also empowers people to take some control over their own health. It also, by addressing not just the well-being, physical well-being, but mental well-being and the social protection as well. And I think the idea around the coordination is that, like, social prescribing is used as a health pathway, which enables, say, for example, a doctor and other professionals to refer patients to support in the community. So the beauty of this is that it doesn't just focus, it focuses on the person's unique circumstances and their challenges, and it connects patients to the support that they need. I also feel that the beauty of social prescribing and the coordination and integration is that it recognises that as good as we are as individual organisations, no man is an island, and there are limits to what we can do, and we can work better together and to make sure that people are supported in the correct way. So I'm a real advocate for that, and I know Healthwatch Bolton uses the social prescribing model, if you will. So, for example, we've had people come to us with one example would be had a mum that's come to us. The child is 12 years old, child's experiencing mental health conditions. The mother doesn't know what to do, doesn't know where to go. So in the first instance, we would refer to a statutory organisation, but we're also listening to other things that the mum needs and what other care is the child and the mum accessing. So then we would signpost to local mental health charities, emotional support charities, not just for the child, but for the mum as well. So it does allow you to be all encompassing too. So I really do feel that coordinating and integrated community services are the way forward. and asked why it's vital to migrant health. I would say in the first instance, the right to health is a basic human right. Therefore, it is essential that migrants are able to access health and social care, and also healthcare or social care as well, but also to tap into community support. Because for the reasons I've just said, it does give people more control over their health. And can I just end that question on a quote, which it's a World Health Organization quote, and it sounds like a bit of a vision, but it should be happening now in reality. And it says making health systems refugee and migrant friendly, and what that means. Like I said, it should be happening now. It means providing quality and affordable coverage, as well as social protection for all refugees and migrants, regardless of their legal status, making health systems culturally and linguistically sensitive to address the communication barrier, ensuring healthcare workers are well equipped and experienced to diagnose and manage common infections and diseases. It's about working better across different sectors that deal with migrant health and improving data collection on refugee and migrant health. So that to me sums up why it is important for us all to be working in a far more coordinated way. Thank you.
Thank you so much, Leah. And thank you to everyone for taking part in today's webinar. I think we've begun a great discussion, and hopefully this conversation can be continued. Just a reminder to the participants today as well, you'll be able to watch this webinar on our YouTube channel, which is BHA for Equality. I've put the link in the chat box. And if you'd like to contact any of the speakers that have spoken today, I've also put their details in the chat box so you can send them an email directly. So have a wonderful day, everyone, and thank you very much.
Thank you very much indeed. Take care.
Take care.
Thank you.
See you later.
Thank you, everyone. Bye-bye.
Bye.